Hi, everybody. So the first thing we're going to do today is we're going to go over the case study that you worked on in class. I'm going to post the notes that I'm going over here as well, but I have things that are underlined and little notes in the border. So I wanted to kind of walk through it. When I'm thinking about approaching a case study or reading an NCLEX question or looking at a patient assessment, we truly have to start in the beginning of the nursing process and determine in that assessment what kinds of things are normal versus abnormal. And in that, being uh, conscious of including both subjective and objective information. So let's just jump right in and kind of look at this case scenario and talk about some things that are normal versus abnormal. And I've gone in here and I've underlined the things that jumped out to me that were abnormal or concerning. So in the beginning, it says Mr. Smith is 76 years, a 76-year-old male. And the reason I underlined that is because we have to think about certain kinds of risk factors and considerations for someone that is 76 years of age. And so we can think about what's going on with that person. An older person is more likely to have chronic disease processes and take more medications, which could interfere with their body processing. And we'll talk about some of those disease processes. We also know that those patients are more likely to become dehydrated and more likely to have a decreased immune response. All those things are things that I'm thinking about, as well as possible risk factors for impaired cognition and impaired mobility, which are going to be important in the health of our patient. And then also thinking about nutritional status. So he's a 76-year-old male and he's been admitted to the hospital. His medical diagnosis is congestive heart failure. And I put in there kind of the definition of congestive heart failure, or nowadays, many times it's referred to just as heart failure. And it occurs when the heart muscle doesn't pump blood as well as it should. So that heart muscle, particularly the left ventricle, gets very weak from pumping so hard that the muscle gets stretched out. So it says certain conditions such as narrowed arteries to the heart, coronary artery disease, or high blood pressure can leave the heart too weak or too stiff to fill and pump effectively. So we're not getting good cardiac output. When we enter the room, we see his positioning. He is sitting in a semi-Fowler's position with the head of the bed at 45 degrees. And those would be things that we would note on observation and want to document. He complains of being tired all the time and barely having enough energy to sit up sometimes, so that's concerning. And we have a subjective information here, quote, "I think I put on some weight. My waistband and shoes seem to be tighter and more uncomfortable to wear." And he also has a history of coronary artery disease, so we know that can contribute to heart failure. And that is truly where those tiny arteries that take oxygenated blood to feed the heart are very, very small. And so there's an increased risk of blood clotting and also an increased risk of trouble getting oxygen to the heart. And if we don't get good oxygen to the heart, then it can't do its job and it has to work really, really hard to get the oxygen it needs. So we'll also look at his lifestyle. He smoked 1 pack of cigarettes per day for 56 years. That's also concerning for problems with the heart and blood vessels. He has no known drug allergies and is a full code status. Okay. So Mr. Smith's high vital signs on admission, 97.7 temperature, that's normal. Pulse of 118, regular and bounding. I'm glad it's regular rate, but 118 is high and it's bounding, which means it's working really hard and really pumping hard through those blood vessels. Respiratory rate is 32 and labored. So it is an increased rate and he's having difficulty with breathing. So labored, we may see things like difficulty speaking, use of accessory muscles, um, a real working effort to breathe. Blood pressure is 160 over 100, and that's definitely elevated. Pulse oximetry reading is 90%. And let's look at this part, at rest on 2 liters. So it's low even while he's resting and even on 2 liters of oxygen. So he's working really hard and it's beginning to not really compensate. So meaning is even with his hard work, he still has a low O2 sat. He denies pain, is alert and oriented, so that's good. He can move all extremities easily, that's good. But he requires assistance with activities of daily living, such as bathing and dressing. And so We would want to understand why. Is it pain? Is it shortness of breath? And the next statement goes on to tell us about it. He becomes short of breath on exertion. So any type of activity makes his heart work harder and his lungs work harder. He states that he sleeps on 3 pillows at home and sometimes sleeps in a recliner due to shortness of breath. So lying down is difficult for him. He gets short of breath. So he's doing things to accommodate and allowing him to attempt to rest with his head elevated. And that's called orthopnea, difficulty resting or sleeping in a lying down position. He's got fine crackles throughout his lung fields. So he's got adventitious or abnormal lung sounds, and that could be fluid in the lungs, and has a moist, non-productive cough. So that means that we can kind of hear things rattling around in there, but he's not coughing anything up. And sometimes that can be fluid that's way down in your lungs. That's not really infection or phlegm per se, but it is fluid that's trapped down in there. Bowel sounds are active in all 4 quadrants, so that's good. Abdomen is protruding, and so that means it's kind of pooching out. And we want to know, is that normal for him or not normal? So many times if we have him lay down and that is soft belly, then that may be normal kind of fat tissue. But if we already know he's having trouble breathing and vital signs are elevated, and he would say that's not normal because he's already said that his waistband is tighter, then we could see that it might be fluid. And with fluid, it would be more kind of abnormal for him and also can be firm. The last bowel movement, it was a formed brown stool yesterday, so that's good. He states his urine output has been small amounts throughout the day and night, amber in color. So amber, we could mean would kind of be on the outer aspects of normal, so kind of a darker yellow. And his urine output's been small, so he's going small amounts when he is going, but it sounds like he's going frequently, so throughout the day and night. So he sounds like he may be retaining some fluid. His skin is warm, dry, so that's good, but it's slightly pale. And so we are concerned about oxygen that's getting to the tissues in the skin. He's on a regular diet, but only ate 25%. So again, we may want to pursue this further and ask him why. Was he nauseous? Was he not hungry? Was he too short of breath to eat? 3+ pitting edema on both ankles. So he's got a lot of fluid on there. And if you'll look at where we documented where the fluid was, so 3+ pitting in both of his ankles, 1+ bilateral dorsalis pedis, and 1+ posterior tibial. So that fluid is going all the way up to the posterior tibial area. He's got a lot of fluid on him. And he states his weight at home yesterday morning was 199 pounds. And today he weighs 205. So that's a 3% increase, about 6 pounds. And so if we look back at edema, that's a mild increase in edema. But it sounds like even with that small or kind of a mild increase in fluid, he already has some cardiac problems. So he's not really dealing with that well as far as heart function. At the top over here on the left, I wrote O2, his decreased O2 to feed the heart. So the problem with his coronary artery disease is he doesn't have enough oxygen really to feed the heart well. And especially when he's exerting himself by doing activities or ambulating, he's getting really short of breath. And it says is that he's unable to effectively pump blood to where it needs to go. So that weakened heart, plus working extra hard with more fluid and more activity, he's just not tolerating it well. So his lab work, let's look at this. Well, let's look at his electrolytes. And I moved down here a little bit and I wrote out the normal electrolyte levels. And I kind of do that when I'm looking at, like I said, whether it's an NCLEX question or whether it's a case study of what are my normal lab values? And so are those normal or abnormal? So his sodium level's normal. His potassium level's a little bit low. It should be 3.5 to 5. And so what I can look at with that and say that if he has a lot of fluid he's holding on to, it may be that it's diluted a little bit from the fluid. Now the other electrolytes, chloride, calcium, those are normal. So what we can see from that is maybe they were on the kind of on the high side a little bit, and potassium's a little bit low. We'll go on to learn that potassium is something we really want to monitor for cardiac function. So we're concerned that he may be symptomatic and have some heart problems. So we're going to watch his heart rate to see if it is regular versus irregular. We probably would get an EKG on him even to see if there is some problems going on with his heart rhythm. BUN and creatinine, I said those are things right now you didn't have to memorize the values for, but I went ahead and wrote down the values for those as well. And so BUN 7 to 20, creatinine 0.6 to 1.2. And if we look at those, they're in normal limits. So that's showing us that his kidneys are functioning well for the time being. The shorter on oxygen he gets with the more effort, it's going to be more difficult to get oxygen to those kidneys. So we are still concerned that he may have some kidney impact if we don't intervene pretty soon. Then looking at his CBC, also again writing normal values, looks like his hemoglobin, hematocrit, white blood cells, platelets, they're all normal. And that would help me to think that we're not having any problems with infection. And then also looking at hemoglobin and hematocrit that are really located in the blood, so in the red blood cells, appear to be normal compared to the other blood cells. But let's look at his arterial blood gas. So I wrote down our normal values here of pH, CO2, and bicarb. And first of all, we need to look at his pH. So we need to see, is it normal, is it acidotic or alkalotic? And if it's 7.34, that is lower than the 7.35 to 7.45 ratio. So if it is lower, we already know that he is in some sort of an acidosis. And it looks like it's a mild acidosis, but it will progress if we don't intervene. His CO2 is 56, and we know that a CO2 greater than 45 is more acidic, okay? Bicarbonate is 32, which is more than the higher limit for bicarbonate. And then looking at his PaO2, which is the partial pressure of oxygen that's carried in the blood, it should be normally 80 to 100%. And so that's the amount of oxygen carrying capability that our red blood cells have. And so that's normal. His O2 sat, we already said, was 90%. And so that should be 92%. So that's low. And if we really compare and see what's in the same column with pH, when pH is low, it's acidic, that would be CO2. So it looks like we have a respiratory acidosis, and bicarbonate is high, so it's trying to compensate. So I would say this is a respiratory acidosis with partial compensation. We're only going to be talking about no compensation and partial compensation in this course. We'll go on to talk about more aspects of an ABG as far as full compensation. And we can say that if the body was fully compensating, if it was helping out so much that it moved the pH back to normal, but our CO2 and bicarb were out of normal, we can see that it was doing a pretty good job of compensating and getting that pH back in range. But the body is only able to work that hard for so long. So this is showing that our pH isn't within normal limits. The bicarb is trying to help, which is great. But we need to try to fix all of those values to get them back into norm. Let me back up here a minute and talk about electrolytes for a minute. So we said they were normal except for potassium. One might think, well, why don't we give them potassium? But here's one of the kind of nuggets I talked about in class. Anytime you have a fluid imbalance, you don't want to jump in and start replacing electrolytes, because what's going to happen is when you're pulling off that fluid, then the electrolyte levels are going to change. So let's say that potassium is normal, it's just diluted by all that fluid. When we pull the fluid off, if we were to add potassium, we could have an elevated potassium, which could potentially be harmful for the patient's heart as well. So it looks like some of our interventions are going to be working at improving oxygenation and pulling water off of this patient, decreasing fluid intake, and then we can get a truly accurate picture of electrolytes. So we always want to correct fluid balance before replacing or pulling off electrolytes, okay? So let's look at his medication. It says furosemide, which is Lasix, 80 milligrams IV now, and then Lasix 40 milligrams PO every morning beginning tomorrow. So in another part, I asked you to tell me, why would he get that? So you have to look that up. And Lasix, or furosemide, is a, a loop diuretic, which means that with the loop diuretic, it's going to help pull fluid from the interstitial tissues back into the vascular system and take it through to the kidneys to get rid of fluid. So we're attempting to get rid of fluid from him. One of the things you'll note if you read about Lasix is that it can deplete potassium quite a bit. So we're going to continue to watch that potassium level. And I would suspect that if we were to give him Lasix now, we would probably be checking that potassium in about an hour to see what's going on. And then if it looks like it's dropping further, we may be given an order to give potassium. So I'm not saying at all that we wouldn't possibly be giving potassium at some point, but we want to start taking fluid off to be able to assess it more clearly. So let's look at our treatment order. So we've got O2, 2 liters per minute per nasal cannula, and our patient's already on that. So maybe when he came from the ER that they put him on 2 liters, and this means we want to continue that. Vital signs every 4 hours with pulse oximetry. So we want to continue to assess his vital signs and oxygen capacity. But remember, we don't need an order to check vital signs. So this is saying, at a minimum, we want you to check him every 4 hours. But since we're taking fluid off this patient, we know he's already short of breath, we can continue to check those more frequently to assess our patient. So truly, when you check vital signs is going to be a nursing judgment when we're talking about assessing for changes in a patient. We're going to do daily weight. Again, we are going to be interfering with fluid balance, and we're going to assess the effectiveness of that with weight. Strict intake and output. Again, if we're taking fluid off, we want to make sure that we are not putting a whole bunch on. So we're going to need that intake and output to look at what we're doing, is that effective? And that's going to be another piece of the puzzle that goes along with daily weight. Fluid restriction, 1,500 milliliters every 24 hours. We said that for the average person, we usually get or should get about 2,500 milliliters a day of fluid. So this is truly backing off from that and saying we're only going to allow him to have 1,500. And so this would be an order that would not only come to us, but it would go to dietary. And dietary many times will put those 1,500 milliliters on the 3 trays during the day. And so those are the fluids that patient can have. So at mealtime, if he doesn't drink those fluids, he may want to hold on to those to drink later, or we have to make sure that we're documenting only the fluids that he drank. So there is some excess that he can take at other times during the day. No added salt diet. So why would we want a no added salt diet? In class, we talked about that sodium is in the vascular system, one of the electrolytes in the vascular system. And if we're taking in sodium, the body is going to want to balance that out with more fluid. And so that's going to pull more fluid into that vascular system. And it's going to make us hold on to more water, basically. So the kidneys aren't going to get rid of the water it's supposed to. And we're trying to get rid of water. So we want to restrict extra sodium on food. And that truly, dietary will take that order and will send trays with no added salt. Activity, bed rest. Why bed rest? Why do you think bed rest? Well, let's look at how hard he's working. Let's look at his vital signs. Let's look at his respiratory effort, his O2 sat. He's working overtime. And if we are trying to assist with oxygenation, decrease the work of the heart, we don't want him up moving around. We've already seen that he has an activity intolerance, that he gets short of breath with movement. So this bed rest is truly to preserve the functioning that his body is doing and not kind of work against his respiratory and cardiac functioning. We're trying to help him with that. We don't want to cause more stress on that. And then the bottom one is IV normal saline at 100. And so one of the questions coming up that I asked was, are there any orders that you might question? And truly this IV fluid is one we would question. This should not be here. If we are taking care of a patient and has a fluid restriction, and we have assessed that he has all this fluid on him and he's having problems from it, we do not want to add more fluid. So whether that means 1,500 milliliters in 24 hours PO, or that means IV, we don't want to add this. So we would want to call the physician and say, did you mean to add this IV order because he does have a fluid overload and is on a fluid restriction. And so we would question that order. Okay, let's move down. Okay, so I've got some notes here, and at the top of it I wrote, consider the patient's age. So any age that your patient is. Is your patient 12? Is your patient 30? Is your patient 78 like this gentleman? Are there any particular risk factors, whether it has to do with safety or the immune response or immunization status? So with this patient, we talked about some of those risk factors or considerations we would have just knowing this patient's age. And we would kind of keep those in our mind as far as some things that may be problematic for him. So let's review the assessment data. Those are all the things there that we said were normal, including our labs. I don't think I wrote labs there, but we talked about them on that kind of front page. And then what's abnormal? So again, I made some extra notes here. Everything from his low PO intake to his pitting edema, low potassium, respiratory acidosis, his health history, so CHF, coronary artery disease, he's tired, he's fatigued, his weight gain, he's a smoker, his skin was pale, increased heart rate, respiratory rate, blood pressure, he's working really hard, O2 status decreased, even with O2 and at rest. He's short of breath with exertion. He has difficulty sleeping, that orthopnea. In his lung sounds, crackles, moist, non-productive cough, abdomen protruding, decreased urinary output. So all of those things that we're looking at as far as abnormal assessment data, these are the things that we're getting together and saying, okay, what does this mean for my patient? What nursing labels or nursing descriptors can I put with this to describe what's going on with my patient? So if he has decreased PO intake, I would think that he has the possibility of, and let's move down here. I went ahead and wrote those down here too. Let's wait. We'll get to that in a minute about nursing diagnoses. What medications is this patient on? We said Lasix. It's a loop diuretic. What's the purpose? It's going to pull fluid into the vascular space to take it to the kidneys to get rid of fluid. We're going to decrease the workload on the heart. We're going to decrease edema. And hopefully we're going to increase oxygen getting to the kidneys. We want to decrease the work of breathing. And in doing that, we're going to decrease heart rate and blood pressure. Anytime you're giving any type of diuretic, and we'll talk about this much more in following courses, you're going to lower blood pressure because you're pulling fluid off and you're going to lower blood pressure. So let's look at the arterial blood gas. And this is from the patient on the first page. And this is truly where I broke it down into pH, CO2, and bicarb. I use the tic-tac-toe method, and I really suggest it. I caution you if you're just writing an arrow next to the pH, CO2, and bicarb in the problem and saying, is it elevated or decreased? Because remember, CO2 has an inverse relationship with pH, which means that it's going in the opposite direction. So you want to think really hard, not just about is it elevated or decreased, but what does that mean for the patient? So in this case, pH was low, CO2 was high, but when it's high, it also means acidosis, and bicarbonate was high. So if we were just to write high or low, they would all be high, or excuse me, pH would be low, but the other two would be high. But when we map it out here, we see that pH and CO2 are acidotic, and bicarb is in the base. So it is truly respiratory acidosis with partial compensation. And what that partial compensation means is that third element, the factor bicarb that's not in the column with pH, is not in normal range. It's in out of range in the opposite direction. And that means it's trying to help. It's partially compensating for the acidosis that's happening with CO2. So it's trying to help. It's having some partial compensation. So review the orders. Which orders do you question? We talked about that, the IV fluid. What's the rationale? So let's talk about why the other things were ordered. O2, to increase O2 to the heart and the organs and decrease work of the heart. Hopefully to help the workings of the heart and the lungs to decrease heart rate and blood pressure. Vital signs, we're going to monitor those for any changes that happen, as well as daily weight. We're monitoring those for fluid changes. Intake and output, monitoring for fluid changes and how they affect the patient's body. Fluid restriction, decreasing fluid volume. Diet, low sodium, and to reduce the retention of water. Bed rest, conserve oxygen, decrease work on the heart. All right, so what are the 4 nursing diagnoses appropriate? And I went through and I named all the nursing diagnoses that I felt were relevant for this patient. So what are those diagnoses? So based on his abnormal assessment, this is what I got. I got ineffective breathing pattern. Now remember, when you're labeling or using a nursing diagnosis, you have to have evidence for that unless you think it's a risk. So ineffective breathing pattern truly shows that his respiratory rate, his pattern of breathing was irregular. Now this doesn't say that this is the only problem I have to fix. What we're going to see is when we look at these diagnoses that many times if you can fix one problem, you can fix a lot of these diagnoses because we're looking at what's causing it. So ineffective breathing pattern, fluid volume excess, activity intolerance, impaired urinary elimination, electrolyte imbalance, imbalanced nutrition less than body requirements, fatigue, risk for falls, impaired gas exchange, disturbed sleep pattern, self-care deficit. And then we would say what self-care deficit? So bathing, dressing. And so all of those are pertinent to this patient. When looking at what is the priority, we're going to say ineffective breathing pattern simply because we are judging that breathing pattern by respiratory rate, O2 sat, use of accessory muscles, all those things. And truly, if we don't help his oxygenation status, this patient is going to become worse and worse until he could possibly die. So helping to correct the things that are causing this ineffective breathing pattern, such as the fluid that's on him, will help this patient. So if we were to take some of the fluid off this patient like we're attempting to, it would decrease his fluid, decrease his work of his heart, his respiratory rate, blood pressure, heart rate. It would help the breathing pattern to become normal. It would also help his fluid volume excess. We would hope it would help his activity intolerance, his fatigue, help his electrolyte imbalance. So there are a lot of things that are going to be affected by this removing of fluid, okay? So then what goals would we set? Just looking back at these, again, our goals are going to be, what are we going to be looking for to show that this patient no longer has a problem? So ineffective breathing pattern, our goal would be that the patient's respiratory rate was 12 to 20. There's no use of accessory muscles. The patient denies shortness of breath. His O2 sat was greater than 92%, okay? Fluid volume excess could be that we are going to, patient will exhibit no edema in the lower extremities, decrease or absence of crackles, decreased shortness of breath, all those kind of things. So what are we looking for that's going to show that this patient's problem is been solved, partially solved, that we haven't solved it, it's actually worse? So then it says, write a SMART goal for each of these 4 diagnoses. Who would we collaborate with? What education are we going to give? So let's look about education. What are we going to talk to them about? Remember, education doesn't just have to be a point in the day where you come and sit down and say, I want to tell you about everything. Every interaction you have with that patient, you should be giving him information about what you're doing, what the things he is, why he's experiencing certain things, what we're going to do to help with that, and asking his perceptions, and also assessing his subjective information. So we want to talk to him about why he's going to be getting Lasix and what it hopefully will do for him. It's going to increase urination, right? It's going to pull off some of the fluid. That's going to cause less edema. That's going to decrease the work of his heart and help him to breathe better. We're going to talk about interventions to facilitate breathing, increasing his O2 sat. So why are we doing the things we're doing? And the hope of the results of that. Think about safety. We don't want him to get up and fall. If he's going to be peeing a lot, we don't want him to think, oh gosh, I'm going to pee the bed, I need to get up. We want to make sure that we say, please don't get up without calling us. You are at a risk of falls and you're already short of breath. So we want to make sure that we're helping you. We want to make sure that the urinal is close by so that he can use it, or we can help him with it and show him how to call us. We want to teach him how the symptoms that he's having correlates with these chronic diseases. So this fluid imbalance is caused by heart failure and coronary artery disease. What are things that we can teach him so that he can prevent exacerbations in the future, and he can identify these signs and symptoms early, that if he is having problems, then he needs to come in to see the doctor. What interventions are we going to perform? So let's look at some of these interventions that we're going to perform to help our patient. Number one, positioning. It's the easiest thing we can do and the most rapid thing we can do to make change. He's in a kind of a low Fowler's. He's in 45-degree position. Why don't we pull the head of his bed up to about 90 degrees? If it's comfortable for him, he's going to be getting the most bang for his buck by sitting straight up in a high Fowler's, where he's able to use that diaphragm more effectively. So I would lift the head of his bed up. Also, we're going to administer Lasix, right, to get the fluid off. We're going to restrict fluids. We're going to monitor vital signs. We want to keep him clean and dry. So if this patient is getting diaphoretic, we want to make sure his gown's clean, his sheets are clean. We don't want skin breakdown. We want to help with oral care. Anytime a patient is on a fluid restriction, their mouth is going to get dry. So even though he has fluid all in his tissues, he's going to get thirsty. So we want to make sure that if possible, we can give him some mouth swabs, but also help with oral care at least every 4 hours so that he doesn't get skin breakdown in his mouth, dry cracked tongue, dry mucous membranes, and it's going to help his feeling of thirst if we are keeping his mouth moist. Small frequent PO, and that's what I mean by small frequent amounts of cleaning his mouth, those small fluids that he can have. In the state that he's in, he's not going to sit there and eat a big meal. He doesn't have the energy to do that or the oxygen. So instead of that, we want to keep him nourished. We might suggest that we order him something like Ensure to have very dense calories in a small amount of liquid. So those kind of things of eating and drinking in small amounts, resting, and then in a little while trying it again. Restrict his activity, decrease the work of the heart and the lungs. Strict intake and output. We want to document. Document is going to help to meet the goals. So we can assess his improvement and the next shift can. And then monitor for complications. What's the worst thing that can happen if he continues to get short of breath and his heart works overtime? He's going to have decreased level of consciousness because lack of oxygen to his brain, increased shortness of breath, and possible chest pain because not getting oxygen to the heart. We're going to watch for those symptoms of complications. How will you ensure that he understands your instructions? We could ask him to repeat them. We know he's short of breath. This could be in short statements. It could also be asking if he has any questions, if he has any concerns, things we haven't covered. But we also want to reinforce information regularly. We're going to be reinforcing information throughout the shift or throughout care with him. When he is stressed, he's having trouble breathing, he's not going to be comprehending really well everything we're saying and listening. He's working on breathing. So reminding and reinforcing as we go along some of the things we may have already told him that he might forget, or that we really want to make sure that he remembers throughout the day. Okay. What is he going to need when he goes home? So we can start thinking about, wow, he may actually need O2 when he goes home. Maybe he'll need placement if he's so weak that he can't go home, or he might need home health. Maybe he needs assistive devices like a walker if he's really weak. So those are the kind of things that we can be thinking about and even document those things, and possibly even in the next day or so, be looking at case management social services to come follow this patient to see, wow, what kinds of things is he going to need, or are the problems getting better and he may not need that. Okay, so on the next page, I had a lot of ABGs because I really want you to practice with these. And I want you to look at when you have a question, particularly about acid-base imbalance. So given some values like pH, CO2, and bicarb, think about what the question's asking you. Is it asking you about what the imbalance is? Is it asking you about what signs or symptoms is this patient going to be exhibiting with these problems? So what kind of things could cause these problems? Or is it asking you, based on that imbalance, how does the body attempt to compensate for that? Those are three very different things. So make sure that you're reading what the question's asking. So let's look at the first one. pH is 7.32, and again, I've got my tic-tac-toe. So that's low, that's acidic. CO2 is 50, that's high, which means that's acidic as well. And bicarbonate is normal, 22 to 26, so it is in the normal range. So this patient would be in respiratory, acidosis with no compensation. So just simply respiratory acidosis. The next one is pH is 7.5, which is high. So that would be alkalosis. CO2 is 37, which is normal, 35 to 45. And so remember, inside that range of 35 to 45 is normal. Bicarb 29, that's high. So that would be metabolic. So that patient has metabolic alkalosis and there's no compensation. CO2 is normal. Number 3, if we look at those values, they're all within the normal range. So though there is no electrolyte, there is no acid-base imbalance. So I'll let you work on some of those. I'm going to skip down to 6. So this is one where we said that none of the values are normal. So pH 7.47 is high, it's alkalotic. CO2 is low, which means it's alkalotic. And bicarb is low as well, which means it's acidic. So with this one, we get respiratory alkalosis with partial compensation. So we don't have to say that it's partial compensation of bicarbonate. We know that if CO2 is the problem respiratory, then partial compensation is happening with the level of bicarbonate. So we would just say respiratory alkalosis with partial compensation. So if you had a multiple choice question and it was asking you about what is the what is the acid-base imbalance, then you would choose the option that said respiratory alkalosis with partial compensation, okay? And I'll let you go on and look at the rest of these as well. So 7 being metabolic acidosis with compensation, partial compensation. And so I'll let you work on the others of these as well on your own. I wrote at the bottom here the next question. So maybe the question doesn't ask you about the electrolyte, the acid-base imbalance. Maybe it says, what could be causing this? Or if these are the values in the ABG and the patient is exhibiting this, what would the imbalance be? So we need to also consider what kinds of things could cause an imbalance. So let's look at that. If our patient is in respiratory acidosis, what are we going to see? It's a respiratory problem. It's the lungs. Acidosis happens when we are holding on to CO2. So we're taking very shallow breaths. We're hypoventilating. This may be that we're taking very slow, shallow breaths, or the expiratory phase is shorter than the inspiratory phase. And so that may mean that I have an irregular breathing pattern. So our breathing pattern is going to look like we are not blowing off a whole lot of CO2, okay? Hypoventilation, low respiratory effort. Respiratory alkalosis, it's still the lungs. This is hyperventilation. So big deep breath, big blowout, big deep breath, big blowout. We're blowing off too much CO2, okay? Hyperventilation, we can think about situations that cause hyperventilation. So it could be that we are anxious or stressed, or we are in an area where there is the O2 in the atmosphere is lower. So places that are high altitudes like Denver, those can cause hyperventilation. We're breathing in real hard to get that oxygen, and we're blowing it off too. We're blowing it off really quickly. Respiratory acidosis, let's jump back to that one. Low ventilation effort. This could be things like over sedation with anesthesia, with pain medication, a drug overdose, ventilation, let me say this right. Ventilator settings that are set improperly. So it's not helping the patient to blow off enough CO2. Metabolic acidosis is for two reasons. One is that the balance, so our body is having problems producing bicarbonate, and that may be kidney failure. So it's not that the body is holding on to so much acid, it's that the amount of bicarbonate that we're producing to balance that out is low. So the acid appears high. So kidney failure. It could also be losing too much bicarbonate. And bicarbonate is lost in the intestines. So once stomach acid passes into the intestines, it is neutralized. It becomes more alkalinic. So diarrhea can cause metabolic acidosis. And then looking down at metabolic alkalosis, it could either be that we're losing too much acid, so that imbalance is off. Metabolic acidosis, or excuse me, alkalosis happens when we're having vomiting. So stomach acid contains a lot of acidic material, hydrochloric acid. And when we lose a lot of that, then it is causing an alkalosis, a metabolic alkalosis. It could also be that we are taking in too much alkaline. And one of the things that can happen with that, let's say that we're taking something like Tums, which is a bicarbonate, to neutralize stomach acid. If we've got an upset stomach, and so taking lots and lots of Tums can actually neutralize that stomach acid and cause an alkalotic status. So it could be taking in too much of that alkaline, okay? Then we can think about the third question. What if we have this imbalance? How does the body compensate? Okay, so let's say that we have a respiratory acidosis, and they say, and the question says, how does the body compensate? Well, if it's a respiratory problem, then the kidneys would compensate. So metabolic with the kidneys, and we would balance out the acid. So with respiratory acidosis, to balance that out, the kidneys would produce more bicarbonate, okay? Respiratory alkalosis, we have too much bicarbonate. So in order to help the respiratory system, the kidneys would excrete out of the body bicarbonate, okay? It's going to get rid of the bicarbonate to balance that out. Now, if it's a metabolic problem, the respiratory system is going to help out. So respiratory acidosis means that metabolic acidosis means that the respiratory system is going to get rid of some of that acid. So we're going to see a hyperventilation, blowing off CO2 with metabolic acidosis. With metabolic alkalosis, we are trying to hold on to more CO2 to balance. And so we're going to see the lungs holding on to CO2, decreasing that respiratory rate and effort. So you can see it depends on what the question is and what aspect we're looking at acid-base imbalance. So let's look at the next questions. I went on to ask you some things about perioperative nursing, simply because I wanted to talk about what are the roles in each of these areas and how do we protect patients. So when we're thinking about pre-op, intra-op, post-op, we're thinking about safety. We're always thinking safety is number one, and that's what I wrote there, safety first. So how do we do that? What is our job? What is our role? Pre-operative. So safety could be patient identification. We're identifying the patient if we're giving them medications, if we're doing procedures like starting an IV, and helping to identify that this is the right person that's going to surgery, right? So the physician could be coming in and initialing or marking the surgical site. We want to make sure that they've identified the patient correctly. We also want to prevent infection, and that means that we're going to wash our hands and we're going to make sure we're not contaminating if we're starting an IV, or if we are interacting with the patient. So using good, whether it is clean technique or sterile technique. baseline. So what is their vital signs? What's their head to toe assessment? What's their health history? We are collecting the baseline, and that's important. Pre-op directions. So did they follow the instructions for surgery day? If the patient's coming from home and let's just say they are getting a colonoscopy, they would have been told to be NPO for at least 6 hours. They would have had to have used a bowel prep that was to clean out their bowels. They may have said, don't take aspirin or a blood thinner that day. So we're going to be asking about those instructions and did they follow those adequately? If they didn't, many times they're going to cancel the procedure because it's either not going to give the results that are anticipated, they won't be able to see the intestines, or if the patient were to eat and get sedation, they could aspirate. So did they follow the directions that they were given at home before they came in for procedure? Also, pre-op teaching. We're going to be talking about things that are going to be helpful after surgery. And so we may think, why don't we just do that after surgery? Well, because the patient is going to have anesthesia and they're going to be groggy. So particularly, we want to start teaching on admission, right? Just like we do inpatient. So that's pre-op. We may be talking about how to use an incident spirometer. We may be talking about patients' activity restrictions or weight lifting restrictions. So don't lift any more than 5 pounds or 10 pounds after surgery. We're going to reiterate those after surgery, but we're going to talk about them preoperatively. And then we're going to be giving report to the next person in line. So that is the intraoperative nurse. We're going to get them ready in pre-op. We're going to get baseline, a history, and then when they go to the operative area, we're going to give report to that nurse. We're going to hand off report. Okay. Keeping in mind that pre-op, they may be getting patients from an inpatient area. So if we're in a hospital, maybe this is a patient coming from the med-surg floor to surgery. So we may be getting report from another nurse. Or this could be a patient that's coming from home to an outpatient surgery center or to the hospital for an outpatient procedure. Intraoperative, inside the operating room. So what is the role of that nurse? How do they protect the patient? Patient identification again. They're going to do something called a timeout. And the timeout is where at the beginning of surgery that they're going to say, we're going to take a timeout. We're going to, all of us in surgery, identify this is the correct patient. This is the correct surgery. These are the allergies of the patient. This is the time expected for surgery. This is any expected complications, all of those types of things to ensure that everyone in that operating room is kind of on the same page and has identified exactly what is going to be helpful and avoiding things that are harmful for that patient. We're also going to protect against infection. We're going to monitor for breaks in sterile technique. So we are the eyes and ears of that patient in the operating room. We're going to watch the anesthesiologist, the surgeon, and everyone around to make sure that they are maintaining sterility. So what that means is that we don't want them to use their sterile gloves to scratch their face or have equipment drop on the floor and pick it up. Any of those things, we are the advocate in there for that patient's safety. And we're going to speak up for them. Falls. We're going to assess for patient positioning, making sure that we're assessing for skin integrity and also that they are secured to the operating table so there's no falls. And we're going to give report to the operative nurse about things that happened in the operating room. How much IV fluid that they took, if they put a catheter in, what kind of surgery they did. So maybe they were going in to do a laparoscopic appendectomy, and then when they went in there, they decided that it had ruptured and they had to do an open procedure. So the operative nurse is going to give all that information to the post-operative nurse so she can pick up care and help to recover that patient in the recovery room. So the role of the post-operative nurse, again, safety, safety, patient identification. They're going to be administering pain medication, maybe other kinds of medication that the physician's ordered in the post-op area. They're going to be assessing vital signs. Again, what were the vital signs intraoperatively and preoperatively? What's their fluid balance? What was intake and output in surgery? What's their O2 sat? What is their perfusion? We're going to be checking for things like pulses and color and skin integrity. cap refills, all of those types of things to assess perfusion. We're going to be assessing pain. We're going to be looking for signs of bleeding. So if they have a surgical site, we're going to monitor that. We're also going to monitor vital signs for things that show fluid loss. So if my patient all of a sudden starts having an increased heart rate and decreased blood pressure, one of the reasons could be that they are bleeding somewhere from surgery. Maybe it is external, we're going to check the site, but it could also be internal. So we want to let the surgeon know if they start to have these abnormal vital signs. And of course, along with that, we would see signs of problems with oxygenation and perfusion. We're going to assess if a patient is alert and oriented. They're going to start waking up post-operatively. So we're going to want to orient them to where they are, what happened, all those things, and assess their orientation. We're going to assess urine output, and we're going to give a report to either the unit in the hospital that they're going to be transferred to after recovery room, post-op, or maybe that patient's going home. So we're going to give instructions to the patient and their family member. We are going to understand that if the patient's had any type of anesthesia, they can't drive. So we're going to ensure that there's someone there that's going to be driving them home. And we're going to evaluate the learning of the things. So we're going to give them instructions in writing and verbally, as well as we're going to help transport them either to the exit in a wheelchair, or we're going to help transport them on a stretcher back to the unit where they're going to. Okay, so I think that was it with the case study. Again, really important points that we're pulling out there that I wanted to touch base with you and kind of review with you. If you have any questions or concerns, sorry, it's late. Don't hesitate to reach out to me. Thank you.